I think I'll make a start. Good afternoon and welcome to the first community of practice event hosted by Technology Enabled Care Team Cymru. TEC Cymru was tasked by Wales government last year to roll out video consulting across Wales to support continuing care to patients who were probably in a very desperate need to access care and support during the pandemic. Obviously, it was not just rolling out Attend Anywhere, but also creating all the toolkits, resources, videos, the training program, which a lot of you may have accessed and are using it. So we know last year's just gone by, and it's probably now time to pause and reflect and look at what we've learned and how we want to take it forward along with us, because I think everyone in this room is probably keen to do the best for their patients and families, and sometimes having difficult conversations can be hard face to face. So how do we do them well when we do them virtually, being sensitive of the issues being discussed, but also making sure that we're delivering the best care? So we've got 3 excellent speakers this morning, but before I start with them, we can go through some housekeeping tasks. For the session, we've muted everybody's camera, microphone, and put off the camera. So we would appreciate if you would continue doing that. The session is being recorded, and the recording will be available for people to access later. We're hoping to make it as interactive as possible, being mindful of the limitations that are there sometimes. So we've got a Mentimeter, and for those of you who are not familiar, it's going to the website, which Catherine has brought up, www.menti.com, and entering the code, which will come up each time when a question is posed to the audience. And you would then be given options that you choose from to the question, and Catherine will be sharing the results of this during the session itself. So we've got some interesting discussion we're hoping to capture via the Mentimeter. We've also got an active Twitter feed, and there's a hashtag Tech Community of Practice, which we would appreciate. And we would also encourage you to join the TEC Cymru Twitter group, because there are lots of events that we're planning in the future, and also to get updates as to what's happening in terms of our research, evaluation, training, and all the exciting things with the program. We're quite keen to hear from you about future events, and if you've got any suggestions, so please feel free to put them in the chat box. Before I introduce my speakers, I would like to say a huge thank you to the tech team. They've been working behind the scenes, especially Catherine, who's only joined us a couple of days ago and has been managing in setting this up. Simon, our training lead, who's again, been working quite hard alongside Catherine. Sarah, our program lead, and Lynn and Gemma, who again have been supporting the team. So huge thank you to you, which takes me to our first speaker, Mrs. Ariana D'angelo, who's a consultant in assisted reproduction at the Wales Fertility Institute in Cardiff. She's also an honorary senior lecturer at Cardiff University, very passionate about teaching and training, and was the past director of the postgraduate training program in ultrasound at Cardiff University, and has an experience of more than 20 years in her clinical field and training. We would like to welcome her, and thank you so much, Ariana, for offering your time to talk about this today. Just to mention, Ariana will be leaving after her presentation, so we will do questions with Ariana after her talk, and then for the next 2 speakers, we've got time for Q&A at the end. So over to you, Ariana.
Thank you very much for the kind introduction, Alka, and also thanks a lot for inviting me to this event, which is very useful and very interesting. I wanted to give a little introduction on what our service does, in particular the Wales Fertility Institute here, as you can see from our logo. We are the NHS provider for IVF in South Wales, West and East. We have 3 bays, one in Cardiff, one in East Port Talbot, which is our main unit, and then in Singleton Hospital in Swansea. We are a tertiary referral centre, and we are commissioned by WISC. So we obviously follow the commissioning criteria for accessing or giving access to our patients to treatment, but also we are regulated by the Human Fertility and Embryology Authority, which is also known as HFEA, is our authority. So it's the government body regulating IVF. So just a little introduction really on the IVF treatment. I'm just gonna, sorry, I'm just gonna try to change the slide. Sorry. Yeah, so the IVF is a complicated story, really, and involves several stages. And many of these stages, I'm not going to explain everything to you, obviously, but many of these stages involve having intimate conversations and consultation with the patient. And it is a very difficult journey for the patient, for our couples. So we have to consult them about everything, which is a personal history, and the consultation itself can be quite intense. It does involve several steps, from the consultation to the actual final step of the embryo transfer, which will hopefully make the patients pregnant. There are many people involved, and I will show you the rest of the team in the next few slides. But briefly, what we do with IVF, we stimulate the ovaries of the woman to produce some eggs. At a certain point, we aspirate those eggs. We put them in the test tube together with the sperm. We wait for the sperm to fertilize and create the embryo, which is the first form of life. And then after 3 to 5 days, we transfer the embryo back to the womb. So these steps requires obviously several appointments, and some of them are now virtual. And as part of the intimate, treatment or information that we need, for example, the transvaginal scan is a typical example. We need to examine our patients, and we need to explain sometimes during the consultation what this examination involved. And we use internal scan, so probes that are as thin as a finger or a tampon, which goes through the vagina, and that allow us to visualize the uterus and the ovaries. And these, again, are that kind of conversation that we embark with the patient. And a lot is to do with when was your last period, how heavy is your period, how many times you have sex, is the sex painful? So it's quite a lot of asking and questioning to our couples. And as I said, the team is broad, and all of us are involved in one way or another with our patients. And starting from the admin, obviously booking appointments, getting the referrals, to the medics who actually perform the first consultations. Our counselors are a very important part to our service, and you will realize more towards the end of this presentation on why this is the case. The lab, we have all our embryologists, andrologists, lab technicians, very much involved in patient's care and patient's contact in terms also of consultation interaction. And then the nursing staff, we have a large body of nurses who are specialized in fertility, and they also very much involved in patient's contact, and obviously our managers who make sure that we do the right things. So what happened then with COVID? In March 2020, we had received the news from the HFEA, from our authority, that obviously we were in a pandemic and all fertility treatment must cease immediately. So we, all the fertility units in all country were shut down between March 2020 and 11th of May 2020, so for a few weeks, and that was obviously needed at the time, and actually it didn't happen anymore. So it was just an event linked to the first wave of the pandemic. We then reopened the unit, reopened the service. It took a little while for our service to adapt because many of our staff were redeployed as everyone else. And then in July 2020, we started full pace, with our to start seeing patients. But the story was very different. We obviously started doing video consultation. You can see here a picture of me because this was one of my first clinic where I took a screenshot to send to my mom to say, now I'm working in a call center, laughing really, because I felt I was really one of the call center advisors. And it took me a little while, even myself, to adapt to this new way to work. But we started in July, and I had a look at my personal consultations since July, between since when I started until the 24th of June, and I saw 376 patients or couples, and had 36 patients who didn't attend the appointment. But consider that our team is made of 6 clinicians, so you have to multiply this number for 6 times. And on top of that, obviously, as I mentioned before, we do not just new clinics, but we do also treatment planning, which are primarily done by the nurses. And the nurses are the one who do a long consultation via virtual consultation via AA with the patients, where they sign all the consent form, which is the regulatory side of IVF. And then obviously counseling is also happening and is counted within the virtual consultations. So in our experience, because I had actually engaged with my team while I was preparing this presentation to try and get also their input for this presentation, for today's talk. In my experience, there are many advantages, a lot of advantages. This actually probably are not even, this list is not even exhaustive. Obviously for the patients, there is no need to travel, and there is obviously a good impact in a reduction in pollution, and we all like to be green nowadays. There is no need to finding a parking space, and we know how difficult this can be in a busy hospital like Landau or UHW. A lot, very, very important, there's no need to take leaves, or special leaves to attend the clinic, and sometimes patients have to take the whole day, because between the traveling and the finding the park and then the delay in the clinic, it just takes a long time. It's obviously a very relaxing environment for them, because they are in their bubble, they are in the comfort zone. And the other very good advantage that I found while I was doing a couple of consultations, it's very important that you can have multiple attendees. So we can invite interpreters if there is a language barrier. The partners sometimes can actually join from a different place. And sometimes our consultation involves also the need to have other specialist input. And we can invite, for example, the embryologist or the counselor or other specialists to give their input. So these are all very, very well-known advantages and very useful points to obviously remember. And disadvantages, in my experience, but I think you might agree with me, is that obviously we rely on technology. So, for example, my computer in the room where I work in my office is awful, as a lot of the computer in UHW, I think. So every day is a surprise. So one day the patients can't hear me, one day I can't hear the patients. Sometimes half clinic is straightforward, and then eventually in the middle of clinic the technology crashes. So it does rely on technology, not just from our point of view, from the clinician point of side, but also from the patient side if they don't have a good Wi-Fi or a good contact. limited view of the patient's body, and reduced value to the consultation. I'm going to discuss this in more details because I think they really are a focus on the day, really, of the presentation. The technology, as I said, bad signal, all computer. Some patients are unable to actually work out the technology, and I had few consultations with a fridge because they couldn't actually reverse the camera, so I had to speak to the fridge, or they were walking around the house trying to find a good signal, and the consultation itself gets fragmented. Sometimes they place the screen in such a way that you either see the cleavage or the top of the head or the bottom. It's not again, you don't have a very good view of the person sometimes. And this is very important for us because our commissioner, which is the Welsh Health Specialized Service, have some criteria, have set up some criteria to access IVF. And people can access IVF only if, for example, they have a certain body mass index between 20 and 30, or they must be smoke-free. So, for example, with a video consultation, what we find sometimes is that we see just the face of the patients, or even up to the chest, and some women have what we call a pear-shaped obesity, and it's only when they attend then for a face-to-face examination that we realize that the BMI is actually over 30, which is the cutoff accepted by the NHS to provide treatment. And the smoking, for example, is another criteria. Before COVID, we used to test patients. We used to do the breath test. So this is the first thing, so which obviously we stopped doing because of the pandemic. But still, you have signs or smell of smoking that you can get only when you actually see the patients face to face. And this kind of these are kind of limitations then for us, because we don't know whether the patient is actually a smoker or not, and we just rely on what they tell us. We had some cases of people who had scars or signs of self-harm, and we only realized that when they attended for the blood test. So we had to access their arms, or if they attend for the internal scan, we actually checked the thighs, the legs, or the belly. And again, one of the criteria for treatment is obviously an impact on the welfare of the child. We have to make sure that we authorize the treatment, and we are comfortable that the couple or the patient is eligible to become a mother, and we have to. That's a legal requirement, but it's also an ethical requirement. So we need to satisfy all these aspects, and sometimes we also find that the partner is very often unavailable, either is in the house but is upstairs, or is busy, or is working in a different room. So we won't be able to speak to the partner. Other difficulties that we encountered is the loss of focus. Some patients are working from home, and they are, for example, in between meetings, between important meetings, and this consultation squeeze really between their work doesn't get enough focus, doesn't get enough importance in a way. They are distracted, they hold back, or they just use the session to debrief a work situation before talking about their fertility journey. And this is one of the comments actually reported by our counselor, that she feels that sometimes they actually not focusing. Interruptions, we get that all the time. I've seen all sorts of pets actually flying, jumping, biting, playing on the desk in front of the computer. Then the delivery drivers comes and knock the door. So we obviously are witness to part of the personal life we would normally see, and it's nice in a way, but it does kind of take the focus and maybe the points of the consultation. So etiquette, I was saying, yeah, patients wear all sorts of things. I just recently I had a couple, they were in bed. One was wearing pajamas, the other one was actually naked, well, like bear on top. They eat breakfast, drink coffee, they hoovers whilst holding the phone. I had one who was sitting on the toilet because it was the only quiet place where they could have some privacy in the house. And we have had all sorts of interaction. And because what we're discussing is pretty serious, we feel that, I feel that perhaps this is something we should look at. So the reflections are really that attend anywhere, for example, from our counselor point of view, it was not found to be suitable to create the counseling setup because she felt that it was too structured and very similar to medical consultations, so very medical. Our counseling sessions usually happens in a non-medical environment, and our counselor is independent from our unit. So she would, for example, send just a very impersonal meeting or neutral invite where she would just say, a word or catch ups with Linda. So just to try to afford more privacy. And she now prefers to deliver sessions either on Teams or Zooms or over the phone or with emails and alternative. And I think she's slowly moving now to the face-to-face. Back again. More reflections from her is that she felt that she would normally be that close to a person's face because obviously on the screen, on the computer, everything is magnified, and she could watch really the patients in the eyes and look how distressed and how upset they are, and that is very important for her supportive process, but it's something that she wasn't used to, so she highlighted as a personal something that had a personal impact on her work. And the same happens to patients. Obviously, a patient normally wouldn't see themselves crying or becoming upset, but obviously because they have the screen there in front of them, they can see the reflection. And we had this discussion with Alka actually at the beginning because this was a problem for us, and she suggested that some clinics suggest the patients to put a post-it on their face so that they don't see their face. So I've got a couple of scenarios now. I think what she described as the scenario from Linda, she's our counselor. She described that sometimes there is when a patient's closed down because the partner interrupts because they're having obviously difficulties within the couple as well, or when the patient takes over the partner takes over the session, is very controlling, very dismissive, then she perhaps starts looking at signs of domestic abuse. Sometimes also we feel that, for example, some patients have barrier language and they don't know how to use the technology. So the husband is there because he's actually controlling the technology, and it becomes difficult then to have a proper conversation with that patient on her own. So normally then a face-to-face session will have to be organized because there will be then some safeguarding issues related to that potential case scenario. And for me, it's just to close my presentation here, is the most hilarious scenario I had was when I had to consult a transgender patient, and he was actually at the hairdresser, and he was putting I was having the dye put on, and he was literally sitting on the chair wearing the gown, having the dye on, and I had to ask him, some sensitive information about the fact that he was actually transitioning from, one gender to another, and I felt that wasn't really the appropriate place to be. So then he moved to his car, all dressed up in this way, the same way, and we had, the consultation, which was like maybe 5-10 minutes. But again, it didn't sound quite right. He was satisfied. We discussed what we needed to discuss. That the main job was done. But it's just to say that we just have these scenarios all the time nowadays. and just to reflect really on these aspects. So I would like to obviously acknowledge and thanks in particularly Linda, our counselor, for her input to this presentation, and I would like to thank you all for listening, and I would welcome any questions you might have. And I'm quite active on social media, so you're welcome to network with me. Thank you.
Thank you so much, Ariana. That was so interesting, and I think it's, although you've introduced humor into it, it just shows some of the challenges that we've had over the last year and how creative people have been in terms of addressing them. I've got a couple of questions. I'll start with the first one. What do you think were the patient outcomes that you encountered while using video consulting, and was there any difference in terms of, patient satisfaction when you were doing it virtually compared to face-to-face?
Yeah, very good questions. We're actually looking into this with the team, with the tech team, because we don't have a proper feedback actually up until now, specifically for IVF, because this went into the pool, I think, of consultations. But we are looking into that in terms of patient satisfaction, and we also looking into perhaps restructuring our pathway, but still continuing using the VC for a specific like follow-ups or for the treatment planning, for specific part of our pathway where it's very beneficial actually and advantageous. But we are looking at our pathway now that the pandemic is kind of easing off, while we hope, and maybe allow some more interaction. We don't think there was an impact on the outcomes as such, but we had some hiccups of patients, missed in terms of, for example, body mass index. That they were just, then we realized that they were not eligible on the day when they came for the examination. So that was probably, not a good outcome for the patients because they were told something else, but we couldn't, without seeing them properly, So, but overall, it's a good experience.
Yeah, no, I've got another question. Any tips that you have in terms of managing the privacy issue that you flagged up during your presentation?
I don't know. I think we will need to have a little bit of code of etiquette for VC, for video consultation for the patients. I can't. I mean, as much as I am supportive and telling them to have sex, I can't have actually video consultation with them in the bed, half naked. That's too much. Too much. I understand that this is what I'm telling them, but it's like. So I think it needs to be a bit of rules like we have with our meetings, and yeah. So that's my point of view. But I'm saying majority of patients are fine, of course, but this is the extremes.
No, and I know there's a lot of work going out around etiquette as well, and how people behave. I'll probably take this as a last question, and we can then go to our Mentimeter. Sarah's asked from Powers, should we be providing pre-appointment information on the expectations of consultations to our patients?
Yeah, that's a very good point, actually. And perhaps part of the expectations could be also the etiquette codes, or explain how things works on the day, and even if they don't have to take the day off work, they still have to have a little bit of time for focusing on this, because this is as important as the face-to-face consultation. We're talking about important stuff. So it's I would definitely take that as a suggestion.
I've got one comment that I'll share from Mirella about thank you for your brilliant presentation, and there have been some lovely comments, obviously, which you can have a look at. I can see the difficulties of handling certain situations, but she wonders if being able to consult from home might actually empower patients, sort of my castle, my rules sort of approach, and that might be more forthcoming with asking questions. So, it's obviously got pros and cons. I wonder if we can go to our Mentimeter, Ariana, before you leave, and just encourage people to answer the question that we're posing. So if you want to go to the website, sorry.
Yeah, sorry, you carry on.
No, this was something that was proposed by Ariana. So for those of you who've just joined, if you go to the www.menti.com website and use the code that Catherine has shared above, it's 93230874, and you will have the question with the options. And if you select that, then we can share that while Ariana is here, because she was quite keen to understand what the audience thought about this. Sorry, Ariana, over to you.
Yeah, no, I was just adding, yeah, we gave some options of answers, so it would be good to see what people think, and definitely, please let us know.
We'll maybe allow people a couple of minutes to log in and ask that, but we'll be more than happy to share the recording and the results with you, Ariana.
Yes, of course, yeah. Thank you very much, Alka. Thank you for listening.
So much. And I'm aware you need to dash off to clinic, but thank you so much for being here and offering your learning.
Thanks for inviting me. Pleasure. Okay, bye-bye.
Bye. So that takes me to our next speaker, and it's a privilege to introduce Jonathan Pierce. And I think one of the things that I've been really lucky and honored with last year is meeting some lovely colleagues who've been doing fantastic work. And Jonathan works as a palliative care social worker with the Hospices of the Valley. And he works with people with life-limiting condition, but also with their families and carers, empowering them, supporting them, and making them make the best of the time that they have before, death, but also works with bereavement support. And I think he's very much patient/client-centered, empowering the patient and their family. And I think he's got strong beliefs around people don't necessarily need professional help, and a lot of it can be offered within the system that is there. He's asked me to mention that he's now got virtual wings and he's flying all over the place. But, he's one of those people you meet and you think, oh God, you must be doing such a fantastic job with the increasing demand he had over COVID on his services. So over to you, Jonathan. Thank you so much for being here and sharing all the amazing work that you are doing.
Alka, thank you very much. And I'm going to try and take you through a brisk stroll as opposed to a gentle walk, really, with regards to some of the technology stuff that we've been involved in over the last 16 months. And I just support Alka's echoes about tweet and following on social media, but just provide a word of warning with it, because this is how I've ended up where I am today. I just basically tweeted about using Attend Anyway as a very useful tool with regards to bereavement support, and before you know it, here we are. So I just want to talk very briefly today about using things like the D words and dying and death. And usually with things like this, I look at the title that I put in, and then straight as soon as I've agreed it, I'm thinking, well, no, hang on, I should have meant dying and death, really. And on reflection, it's just not differently, but it's a bit the same as well. So even though the setting has changed, the context has remained exactly the same. So just to give you a brief potted history, pre-COVID, a lot of bereavement supports was face-to-face. We do visits, cavorted around the valleys of Blaen y Gwent, sat in people's kitchens, sat at their table, hoping being invited to have a cup of tea, waiting sometimes for the neighbour to knock the door next door just to see who's visiting. And we just didn't just do face-to-face and one-to-one work. We did kind of various groups based on people's bereavement needs as well. Within Blaen y Gwent, we've always provided hospice and non-hospice bereavement support, but during COVID as well, we've offered non-hospice bereavement support to the Merthyr Tydfil area as well. So I think maybe during COVID, I think some of the pattern of work has been the same as everybody else. I started I think the first month, March to April, like the rest of the world, wondering what was going on. And then steadily used telephone support, continued doing visits for people that needed them with PPE. And as the summer came, which doesn't happen very much in Blaen y Gwent, we've got a nice little garden here with a garden room, and done some face-to-face visits just to prevent us using masks. And eventually, come the autumn, when the weather was getting a bit tetchy on the socks, I looked further into it anyway, really. And I think probably since the autumn onwards, that's when we've been using technology to its full capacity. So I'd like to think now we're quite adept at using a platform such as Attend Anyway. We've used Zoom, we've used Teams. I'll go into that in a bit more detail. And I think when Alka very kindly asked me to present today, a little model came up for me, really, and we call it the peers model, because I like quite uncomplicated, simple things to kind of follow as well. So the P is preparation, and preparation is key. And just to tip a compliment to TEC Cymru, doing the virtual training and particularly the resources will probably address some of the issues that were asked as questions in Ariana's presentation, really. So preparation is key, and just gaining some knowledge and basically not having to reinvent the wheel, because there are resources available. You can send information out to people. You can tailor them to your own degree. You can mention things like GDPR and confidentiality too. And as a practitioner, what I want to do is just provide a service. I don't want to spend too much time really coming up with all these other bits and pieces. Preparation is useful because my first experience of Teams was presenting to a cross-party group on hospices and palliative care. And I've got my presentation today blue tacked to my screen because I'm better doing that than with PowerPoint. And for the first 30 seconds, because I had a lovely frame of post-it notes around my laptop, and it was the first time I'd used Teams, I couldn't find the mute button. So I had one of the Senedd members very kindly asking me to search for it. So I think one of the things today is we need to embrace change, because if I can get to the point where I feel reasonably comfortable enough to provide video consultations, then kind of really anybody can. And for me, I think it's reducing tech anxiety, and that's particularly for me as well. We provided bereavement support, and all very, very complex bereavement support all the way through the last 16 months. And for me, it's the anxiety with making sure the technology works is more of an issue sometimes than actually the subject matter itself. So I think for me, it's having a bit of a plan B and making sure you've got telephone numbers to hand just in case for some reason it doesn't work. And teamwork and support without a shadow of a doubt. So I use my clinical admin team now to set up any of the closed bereavement groups that we do, or if I want to send invitations out to various things, it's just making sure that as a practitioner, I want to get on with the job in hand as opposed to spend a lot of the time doing the other bits and pieces. So I've got the beauty of that, and it's very much a teamwork effect. So the E of P is environment, and what we're looking for is recreating the benefits that we had prior to having to use video technology. And things like setting the scene. So we've already discussed avoiding distractions, making sure that that space is confidential, and confidential for the person that you're speaking to, but equally for us as well. And I think coming to an empty room like we've got here, to allow myself to be as focused and intent as I can on the conversation at hand has been a revelation, really. And being grateful to work in the workplace and not at home as well, so having that separation. So I've got a private room. I haven't got the distractions of other colleagues. I'm kind of nosy by nature, I guess, so I think I wouldn't do myself a service to the person that I was supporting if I was in a room with somebody else. And having the proverbial cuppa, which I'll reach for now as well and have a little sip at the moment. And it's back to recreating that atmosphere, that environment that you would have had if it was face-to-face. And things like the extras, so the headphones that I've got on today, I remember in the late 70s, my nan having a landline at home. And when it first rung, she was shouting at it. And one of the things I always remember is I don't really want to turn into my nan doing things like this. But it's having those prompts to hand as well. So I've always got a bit of chocolate by the side of the desk. if I've had a telephone consultation with somebody prior to the video appointment and they get quite distressed, it's just reminding them to grab a box of tissues and keep them at hand if you need to. But equally, if you are engaged in the environment as well, is just saying to somebody, go and grab yourself a tissue if you want to and come back. Which takes us on to engagement. Now, this has been quite comical at times as well as very successful. And I think it's just realizing that, we can do it as good as we can. And as Ariana said, some situations we can't control. So I had a lovely pre-bereavement appointment with a mum and 2 young children where I was supporting mum to support her children to talk about dad's cancer of the tongue, and she was talking, the little 8-year-old, about daddy's got a hole in his tongue and prompting her with what it's called. And while we were doing it, the 4-year-old's cartwheeling on the bed in the back and putting her nose up to the screen. So, but in some respects, it's no different to actually having that consultation with family members. And from an engagement point of view, I think we've gained so much. I always ask the person to tell the story first. So if it's a second appointment, to feedback on the previous session, because I think our model of bereavement support is very much based on resilience and people's innate ability to cope with those around them. So it's very, very useful for me, and the feedback has been quite helpful for them to be telling us what's been useful the previous times as well. And the skills that you can use are no different to the skills I'm sure that you already use. So having that presence, I think it's got to the point now, I think we've conducted over 100 hours on the Attend Anywhere platform and run various groups on Zoom and Teams as well, is that sense of presence can be captured if you've got the right environment that's conducive to the conversation. Body language as well, and there's some losses because you can't see the full body, but there's some gains because those facial expressions you can pick up more sometimes on a video appointment than you would do elsewhere. And things like silence, I found it, and it's a skill that you develop. You find it very, very satisfying not having to fill the gap. So just giving somebody that time and space. And if it's over the telephone, I found it a bit more of a challenge at times, but certainly via video, it's been very, very powerful and purposeful for both parties as well. And it gives you time to respond, not react as well. And it gives me still an opportunity to use words like dying and death, those concrete words that are so important for people. And the R for my peers model is a sense of realism, really. So it's recognising and knowing your audience. We've got quite a high rate of poor literacy in Blaen y Gwent, so it's not a service that's going to fit all, but it's part of a repertoire of different services now that we can offer. So it's realising that sometimes face-to-face may be something that individual may choose to have, but it's not the first choice we have to provide all the time. And irregular self-care is very important as well, because we've been inundated with referrals at times, and some of the non-hospice bereavement requests have been very, very different to that planned and supported and expected dying and death process as well. So it's recognising that for yourself, you make sure that you pace your working day accordingly and consider the frequency of appointments and the number of appointments that you put into your diary as well. Because I haven't got the advantage now of driving in between visits, debriefing, catching up on the sports news on Radio Wales or anything else. And it's about appropriateness as well, so that the timeliness of the referral may not be right sometimes, or it's recognising, as I said earlier, that if you look at bereavement and look at resilience in bereavement, not all people need professional bereavement support. And it takes me on to sustainability, because you need to have the resources to do this job as effectively and efficiently as you can, and to be satisfied and not be professionally frustrated as well. So it's making sure you've got the right equipment, making sure that the time is planned, and things like having yourself an hour's appointment, but maybe spending 45 minutes to catch up with your notes, grab a coffee break, grab a bit of time in between appointments with a colleague that you value, and having a plan B in place just in case the internet doesn't work or something like that as well. But the flip side is, of course, is that the travel time cuts down, but you can balance that and offset that too. And it can be best fit for both parties. And you can question the norm that you had previously. Well, how effective was it? And going forward, it adds value to the service as well. So there's options and opportunities for all. I know for me now, for lots of people that refer to our service, a face-to-face appointment is probably an appointment of choice. But we've got different kind of means and ways now to provide a more effective and efficient service as well. And we don't have to have that neighbour knocking that kitchen door. And the feedback and the cycle as well is very, very important as well. And with the TEC Cymru training, you can have a look at kind of investing in things like SurveyMonkey or using some of the more traditional methods like feedback and evaluation forms as well. And I've had a lovely journey with a lady whose mum died back last autumn, and she've had the kind of the full shebang really with regards to pre and post bereavement support. So we started having a visit at the home with PPE. Mum went into a local hospital. She had some garden appointments here. History of anxiety, and we got to the point where we supported her as a wider team and the family for Mum to die at home, and she described it as a beautiful moment. And subsequently, she had some attend anyway appointments. We then run a grief hurts group, which is a closed group for people who still need a certain level of support. And now that group's completed, she've asked the other members, would it be okay if she actually continue the online support as a peer support group as well. So it's a lovely little story. And I guess there's a few things for me to conclude, that we need to embrace and not resist change. And by choice, this technology didn't come along, and I probably would have looked at it prior to a pandemic, but it's been a fantastic addition. And I've learned as I do, and that's to do with mistakes as well as successes. And one of our successes last week in our closed group was one of the members was so determined to attend our bereavement group that she actually listened in on the train on the way home, and then ran across the station into the car and participated for 15 or 20 minutes then via the phone. So there's a very much a can-do approach by people that if they want it. And we are able to look at the emotional and social determinants of bereavement, loss and grief as well. And it's great to have an opportunity to work alongside some fantastic welfare rights advisors that provide that kind of holistic and total support really, because without having food on the table and a roof over your head and money in your account, it's very, very hard to be transfixed by a lot of the emotional consequences. And I guess just to sum up, it's just reaffirming that not all bereaved people need professional help. And what the technology has enabled us to do is to spread our wings technologically. And we provide online bereavement information sessions, we've provided training, we've provided face-to-face work for a number of people, but a gentleman with learning difficulty springs to mind that we eventually run a Teams training session for his wider team because he needs that ongoing support. We provided consultancy supervision, work with schools, and a lot of partnership working, because what we want ultimately is to increase everybody's confidence and competence when discussing dying and death. Thank you, Alka.
Thank you, Jonathan. That's so inspiring. And thank you for sharing all those cases, because it just brings it to life. And I think you should copyright your stroke peers model now. Before we move on to the next speaker, Catherine will be sharing the Mentimeter with the question that Jonathan wanted to propose to the audience. So if you want to have a go at your Mentimeters again, and we will come back to Jonathan with questions at the end of the session. But it's just wonderful seeing how you've demystified all the stigma around death, dying, and having those conversations, which can be so difficult even face to face. Some lovely comments coming already, Jonathan, and I'm hoping we'll have time for question and answers as well. Maybe we'll share all the Mentimeters towards the end, but talking about stigma takes me very nicely to our next speaker. And again, it's been an honor getting to know Darren. And I first saw him on the telly. He's been very much involved on the Fast Track Cardiff and Wales initiative of destigmatizing HIV, where he's working with clinicians, patients, Welsh Government and university. And they're keen to get rid of the stigma by 2030. He's a consultant in sexual health and HIV based at the Royal Infirmary, and has huge interest in biomedical HIV prevention services and clinical informatics. Very keen on services being built around patients and not patients having to fit around services. And also he's been instrumental in writing the national guidance in STI management. So over to you, Darren. Thank you so much for joining us today.
Okay, thank you very much, Alka. Thank you very much for the introduction and inviting me to speak today. So I phrased this consultations without masks. And really the idea is that all our face-to-face consultations we've really had since COVID have been behind a mask. So actually, if you're using video consulting, then you don't have that barrier. So this is myself. I'm based at the Royal Infirmary in Cardiff, consultant in sexual health and HIV, and work very closely with Fast Track Cardiff, which can potentially follow us through Twitter, and you'll find out a bit more information about. So we had wanted to use video consults and new means of communication prior to COVID, but we'd had various organisational barriers in place for that. We had a situation where a lot of our sexual health consultations were face-to-face and involved 20, 30 people sat in the waiting room, which obviously in a COVID situation is never going to be sensible to have lots of young people who are sexually active with potentially different partners in a situation where they could pass COVID to one another. So a lot of our organisational barriers really disappeared actually, or evaporated. We had initial high take-up within our HIV service, so looking after people with a chronic medical condition, and also specifically with some of the counselling, the psychosexual counselling elements to the service. And I would say there's a high confidence in video consulting amongst both medical and non-medical staff members. Huge praise to the pharmacists who run their own clinics in the HIV service, who really took this up with gusto and had a very matter of fact, yes, it's here, we'll get on with it approach. I say high confidence in medics. Some medics took it on very quickly. Some people struggled with the technology. Some people struggled with the approach. So some of the learnings I think we've had in sexual health have been that you need to have a development of a webside manner. And I kind of roll my eyes when I say that instead of a bedside manner, but this idea that you've got to know how to make a consultation work, which is slightly different from a face-to-face consultation. You've got to minimize distractions, because I think it's very clear that particularly in our HIV service, you've got multiple screens up and you're looking at the patient in one screen, but on the other screen, you've got their blood results, or you're typing in their clinical record or doing a pharmacy prescription. And my understanding of the evidence is that patients can spot a mile off if you're not giving your full attention. So my strong advice would be to minimize any distractions that you have, or be very explicit about it and to say, I'm just going to do your prescription, so I am listening, although be cautious that the patient might interpret that as in you're not listening. Very important to confirm name and date of birth, which sounds again really obvious and something we should do in practice in face-to-face consultations, but probably don't all the time. And I think it's doubly important if you're doing a video chat into someone's home, because is it really the person that you're seeing, or is it their partner, or is it somebody else? I've had experience on Teams with my children having online lessons, and actually without me watching, one of the children was booted off and the wrong child was having the wrong lesson at the wrong time, which I only found out a couple of minutes later. So to check who else is around, I think we've touched on this before in terms of distractions that the patients might have. In sexual health, we've always very much gone down the route of, for patients having their consultation, this is one-on-one. So you don't really allow other people into the consultation, because even though somebody may want their parent there, they may want their sibling there, they may want their best friend there, when you start getting onto very personal situations with them, they might not necessarily want them, their best friend, to hear all the details of various sexual encounters. So we're very cautious of that, and that was a nervousness that we had going into this in video consulting. But actually, I think on reflection, it's kind of helped us, because we've started to see people in their usual environment, and particularly some of the work we have about sexual exploitation, vulnerable adults. Sometimes it's quite useful to know the patient's ecosystem, to know who they're living with, what's the relationship there. And particularly the first presenter mentioned about potentially signs of domestic violence or intimate partner violence. And if you do have a partner there who's taking over the consultation, then that may give you the clue as to some of the dynamics in the relationship that you wouldn't necessarily get face to face, actually. We do IPV, intimate partner violence screening, for all our consultations. It's a requirement that we have within the service. But we know, again, from the evidence that it's not that people disclose their IPV when they have a sexual health consultation, but they feel that they have the permission to disclose it. So they might not disclose it on that occasion, but they know it's okay to talk about it. So then if you have a consultation a few weeks or months or years later, they know that this is a safe place where this can be disclosed. And I think that's a crucial difference. A nervousness we had in sexual health was about the legislation that may affect children and young people. So there's a specific criminal offence which is to do with encouraging a child, so somebody under 18, to take an intimate picture of themselves and to send it electronically. So there was a nervousness for some of our patients where, oh, I've got this rash, doctor, and people would, pull their trousers down and show you their genitals on the screen, which was never borne out in reality, that if a 16-year-old does that, then actually organisationally you might come into trouble, actually, that you're encouraging somebody to do that. So there's a bit of nervousness there that's not really been borne out in practice. So I've got a couple of cases just to mention. So basically, the first consultation that I'd really mentioned was a 36-year-old who was a migrant asylum seeker who came to the UK from an Asian country. He gained his leave to remain, indefinite leave to remain, and part of his asylum process was about his sexuality. So he's a man who has sex with men, which is the term we commonly use for gay and bisexual guys. So his English was okay, but he did get lost in nuances. So he's someone who I think ideally you'd probably want a translator, particularly if you're talking about quite in-depth conversations, but he really didn't want that. And there was a mistrust he had with doctors and nurses historically, and I think we would take it for granted that a sexual health consultation in the UK isn't going to lead to a criminal prosecution. But if you come from a country where sodomy is punishable by death, at least in the legal statute, then there is a genuine or perceived concern that someone is going to, a doctor is going to leave that consultation and phone the police, and the police will come around to your house. So video consults put him a little bit on edge initially, but he was quickly reassured. He went into the MSM dating scene in quite an unprepared way. And by dating scene, I'm kind of meaning sex on demand apps. So he kind of ended up in a situation where there's a lot of slang, a lot of negotiating sex at short notice. And he particularly ended up into some of the S&M scenes, so some of the fantasy coerced sex. And it was a situation he was really not prepared for. So he ended up in a situation where he had a random meet with somebody where he was essentially held against his will and assaulted over a number of days. Obviously the police were involved. There's a huge forensic side to this, but he certainly felt that he was unprepared for this, and that he was psychologically distraught at the end of this. So he was in our counselling service, our psychosexual counselling service. And there was really, really positive outcomes with the consultation that he had. I think the quote from him is that he could not have done this face to face. So it's not that it was easier, it's not that it was beneficial, it just wouldn't have happened face to face. He would not have turned up to that appointment because he was so scared in various ways of disclosing information, but also having that trust. The counsellor that was present is someone who was going through the process of retirement. So she was an experienced sexual health nurse. And she is somebody who I would challenge always any stereotypes of who fits in with video consulting staff-wise. It shouldn't make an impact, but the preconception is sometimes there. She was in her mid-60s. She was proud as punch that she was one of the first people to get on board with Attend Anywhere and the video consulting software. She was proud of punch to be seen as an innovator, and the move towards video consulting and online consulting is something she'd wanted to do for 20-30 years, but really lacked the organizational get-go to do it. So she really helped spread the word as well, so helped convince other people who were perhaps a bit more skeptical that this was a way forward. So really positive approach there that helped. So the second case, I'm just keeping an eye on the time, so there's a little bit to go with this. This is a somebody who presented to our PrEP service. So PrEP is biomedical HIV prevention. So you take a tablet a day if you're higher risk of HIV acquisition. So usually gay and bisexual men, but sometimes trans women, sometimes sex workers. So someone presenting to our service, now in theory, you shouldn't be having casual sex during COVID, during the height of the COVID lockdown, but we know people were, albeit in less numbers. And this guy was a 17-year-old guy, again, came to the UK from a Middle Eastern country, very well-off family, very well educated, so was educated in the West, and was effectively a very confident young gay man who walked into a police station in another UK city and basically walked out of his extended family and turned his back on them from a very young age, and ended up in Cardiff residing with foster family as he's technically a looked after child because he wasn't quite 18 yet. He had historic sexual abuse in his home country that was completely hushed under, but also his family were openly homophobic. They had death threats. They were actively searching for him. So for us, he's very well adjusted, very different to the first case, and he approached us for PrEP. Now, actually, through telephone triage, it emerged that some of the signs we look for child sexual exploitation were present with him. So he was using online dating, and he was sometimes having sexual contact with people who were 3 or 4 years older than him that he was meeting through apps, which kind of raised alarm bells. And there was a general consensus in the MD team that a face-to-face was needed. So we went down the route of video consulting, so rather than mask-to-mask, face-to-face. And I think it was really important to understand this looked after child in context. He had a happy home life, he had no coercion, he was articulate, he was confident. And I think the approach that we took landed him on PrEP, which is great, but also it created this, I would say, a therapeutic, a positive approach to prepare this guy for adulthood. So rather than having the stigma, if you like, of being a looked after child, having to come to a face-to-face appointment, having to have quite intrusive questioning, we were able to get much more relaxed history from him. So not only were we answering the CSE, the sexual exploitation risks, we were able to talk to him about negotiating safer sex. You know, he's someone who's going to go to uni, he's going to go out in society, and to understand relationship dynamics and why negotiating safer sex, particularly in an online setting, can be quite beneficial. So he left very satisfied. And I think as clinicians, we were very satisfied that we were providing a good service there. So in terms of future developments, we are looking at how we're going to move video consulting into the hybrid model that would be post-COVID. And there's a real spectrum of feelings in the department for, do you use video consulting all the time for things like HIV management? Is that suitable for everybody? Or do you have some hybrid approach where you have the odd face-to-face? Or actually, for some people who really don't want to sit in a waiting room or have another job, thank you very much, don't want to feel the stigma of having to come to regular appointments, can we build together a model that fits what patients want and fits with their kind of lifestyle rather than fitting with ours, which is something I feel very passionate about. We're also potentially using Attend Anywhere in a group setting. So one of our health advisors is trying to do some sex addiction work to where there's really good evidence for group work in sex addiction, and particularly amongst the gay and bisexual male community, that people who are taking chems, so-called chemsex, so taking recreational drugs and then having a lot of sexual partners, group-based sex ed, group-based sexual interventions can be quite helpful. Now, the problem is, of course, if you have face-to-face, if you put a group of people who have problems with disinhibition and sexual contact in a room together, then there is a slight chance that they might go out of the room and all go and have sex together. So there is that nervousness that we have. So actually using the online forum can be quite helpful there. So that's the direction where we want to go. But that will take a little bit of work in terms of building that together. So I think in summary, I value talks like this because I think there's a wider understanding of what we do in sexual health, which I think helps us. And we're trying to destigmatize what we do in sexual health and make it more mainstream. We would like PrEP to be available, for example, in GPs and primary care centres and community pharmacies. And part of that is getting the word out there in terms of what we do. There's a redefinition of what the consultation is. And I saw the talk before about potentially devaluing some of the elements of the consultation. But I think sometimes as clinicians, we need to answer back, well, what exactly are we offering and why do we need to have so many consultations, so much follow-up? And also, we know that the service is safe and effective and even sometimes beneficial over face-to-face consultations, particularly in the COVID era, but potentially beyond. So, acknowledgements, staff and patients at Darsh Department of Sexual Health for going through this. Phil Edwards, who I've checked is not on the call, but he works in primary care in Cardiff and Vale, who seemed to be a magician to conjure up headsets and monitors at short notice in the height of COVID. The Attend Anywhere team in Cardiff and Vale, and also the TEC Cymru team for helping us here. So I would move back to questions.
Thank you, Darren. Before we go to questions, maybe we take the Mentimeter question for Darren, and then Catherine can collate all that for the end. So it's the same link, the same code, and a couple of options as to how you manage other people in the background when you are having sensitive conversations with the patient. So I'm wondering, while people are answering, whether we can open up to questions, because I'm mindful of the time and I'm aware people probably need to dash off to their commitments. Firstly, question for you, Jonathan. How have families reacted or accepted the use of virtual consultation for bereavement counselling? And do you feel it has the same impact and helps them cope?
I think I've probably mirrored the other two presenters here, Alka, today, and said there's a space for it, not to replace, but to put alongside, really. So it's just, for me, a question of ongoing assessment to determine what's the most appropriate setting, really, maybe for that individual and for you as a service as well. So I think there's quite big challenges going forward. I think there could be resource implications for depleted teams, for example, which could cause burnout, etc., as well. So it's just, for me, it's a chance to have a plethora. So for us, it's always been people want face-to-face appointments. So for us, we're able to be in a position now to say, well, we may not be able to provide that currently, but would this be good enough? And if the outcome is yes, then there's a space for it. So the feedback has been as good as face-to-face appointments. And I think, as Darren's just said, now that context, that setting, if we get that right and prepare people, it can be more effective, I find, than a face-to-face appointment.
Okay.
We have had the issue where our administrative team have kind of struggled a bit. So for chronic disease management in HIV, you would give the patient the slip that says, take this to reception and book your next appointment. And you find yourself doing that and then saying to people, can you be seen 6 months a week on Tuesday? And that has been a struggle in terms of working out a way of divulging that back to the administrative team, because it makes your consultation a lot longer.
Yes. And I found using Attend Anywhere, booking my own appointments instead of asking my clinical admin colleagues has been much better as well. So from a time efficiency point of view, it's been far more useful to have that conversation with that individual and back it up with an email or a text to confirm as well. So, yeah.
Thank you. And again, I know both of you sort of referred to stigma in different ways, but Darren, I don't know if you want to take the question, and obviously, Jonathan, you can chip in. But it's for you, Darren, to think about, do you think the stigma associated with sexual health and HIV is probably faced with the same intensity when you're seeing people virtually as to seeing them face to face, so be it the waiting room when they're waiting, or, there's a feel that you get when you're engaging with them?
Yeah, I think particularly in HIV, there's the concept of self-stigma, that people feel they're HIV positive and actually their own well-being is affected because they feel that they've done something wrong. And I think, and they may feel like every day when they take an antiretroviral tablet, but certainly to sit in the waiting room for 2 hours makes people feel low. And then when you check the blood pressure, it's always high. And, a lot of our patients have symptoms of anxiety and depression, which are probably the same, almost similar if someone had chronic psoriasis or other medical conditions as well. But I can't help but feel that the VC sometimes destigmatized by saying, well, it's okay, you can do this at work, you can close the door if you've got a private office, or you can do that in the comfort of your home, and you might get a better outcome in terms of you get more honesty or more thoughtfulness from patients in that sense. So potentially.
Mm-hmm. And anything to add, Jonathan, based on what that?
I think we've reinvented dying and death as one of the biggest stigmas, where a generation or two ago it wasn't the case. And we often hear about being in a room full of people, even if it's virtually, and feeling all alone. So I think just by having this very short, sharp and effective approach sometimes just really supports people to get back out to their local communities and gain that support. So whether it's the bookie, the woman down the chip shop, the chapel, it doesn't really matter to us, does it? As long as it's kind of refocusing people, because I like to think I do a good job, but I might spend an hour a month with somebody. There's a lot of hours in between. So I think, we need to be, helping, supporting people to recognise their own ways of coping as much as they can, which helps us as specialist services as well then.
Yeah. I've got some nice comments as well. And, this is from Sarah from Powers saying that she thinks services with blended option face-to-face and virtually is the way forward. We've then got another one based on the Mentimeter. As to the last question on the Menti, would it be better to advise that intimate, difficult questions may be asked and the client can have some autonomy on how these questions are answered and won't feel so much like the questions being sprung on them? And I think, we're learning as we're going along. So again, question for both of you, be interested in hearing if others have set up successful group video calls, and maybe you can talk about your experience, because I was quite keen to understand the confidentiality element in group setting. It's hard enough when you're doing it face to face, but how do you set the ground rules and how do you make sure people follow them? So I don't know if you want to answer, Darren, and then Jonathan, you want to.
Yeah, it's not something we've done so far, but we're definitely looking into. The other thing is potentially demedicalizing it, and so we have third sector groups that are looking to do peer support in particular. So these people are often well experienced with the whole confidentiality thing of getting a bunch of people who are HIV positive in the room together. So I would probably draw from their experience in terms of how to go. But I must confess we haven't gone that far so far.
Okay, and I know, Jonathan, you've done a lot of work around group work, so.
We have. I think as health and social care professionals, we often decide what's best for people and we wrap ourselves up in knots, trying to think of reasons not to do something. So I think for me, the TEC Cymru training with the template letters that were sent out, Alka, which you can then add to, so things like confidentiality, is no different to the issues I'd have with a group in a room as opposed to virtually, really. So it's back to those kind of solution focused reasons to, as opposed to reasons not to. But it's reminding people cameras on, nobody else at home. If you suddenly go off the call, we will follow you up with a phone call potentially. It's all those good practice things that we probably would have done already. Just we can't have a cuppa and a box of tissues in the middle of the table. That's the only difference.
And again, this is a question I was going to ask. It would be good if, and I know if you've already done that, when you are doing group sessions, because there'll be so much similarity in some of those ground rules, and whether you had a script that either of you had put together, and we would love to share that, with the wider audience, because that would be such a useful resource when somebody's planning that.
Mm. Yeah. Over to you, Darren.
I would be more than happy to share things, actually, but I must confess we're still at such an early stage that that we haven't got that far yet. But I definitely love the idea of doing what patients want and what service users want, because I think, again, we wrap ourselves in knots as healthcare professionals. And I think sex and death, they're kind of, people see them as being very stigmatizing. And I don't know, Jonathan, if you have a similar thing, but our corporate hierarchy sometimes hear sex and sexual health, and then they just go into a frenzy with them. Oh, we can't possibly talk about that, and we need that reassurance really that it's okay.
Yeah, we have the similar with the D words. It's just kind of almost kind of chucking them out there all the time, really, and use them as much as possible. And I think you know me already. My presentation day was blue tacked to the screen, as opposed to any kind of PowerPoint. So I can come up with something as a script. It's certainly not something I've got already. And I co-facilitate a lot of groups as well with my colleague Jill. And our mantra really is one of us pausing for breath for the other one to interject. Usually, it's as scientific as that.
Thank you again. Some comments. One drawback with video groups is you can't know who else may be in the room behind the camera, who would then have access to other group members' intimate information. And I suppose those are the things you would address as ground rules in any group, face to face or otherwise, as to how you share information outside that. And lots of lovely comments for you both. And I just wonder if we can pause and maybe look at the Mentimeter question, because we didn't get a chance to look at the last one, if Catherine's able to share that. But some great comments about interesting presentations, and it's really got people stimulated. We are 63% advised that when you know about, discuss confidential. Yeah. So we'll be sharing all the results on social media as well and the recordings, but we've done okay time-wise. I was worried that we won't have opportunity for questions, but if there are any more questions, we'll send them to our speakers. And thank you once again to both of you and to Ariana. I know she's left, for being here and sharing some of your learning, because these can be very challenging conversations to have. And we'll stay in touch. We're hoping that we'll have some ideas for future events. And thanks to the tech team. And again, thank you once again. Have a good rest of the day. Bye.